Everybody hi! Acute Inflammation is an evolutionary conserved repair program that stabilizes damaged tissue and manages the entire complex process of structural repair and functional recovery. Within the broader framework of the Disease Optimality Principle declared by us, its efficiency depends entirely on how effectively local responses and systemic regulation remain synchronized over time. The clinical panorama of acute inflammation is highly variable, strictly dependent on several factors, including the nature of the damage, aseptic, bacterial, viral, chemical, etc., host factors, age, sex, and exciting risk factors, especially genetics, environmental factors, diet, temperature, pollutants, and chronic stress exposure. However, the global underlying mechanism remains consistent. This is because nature did not develop specific, unique mechanisms for inflammation. Instead, the inflammatory process represents the superposition of basic ganglionated physiological mechanisms such as vascular tone control, blood clotting, chemotaxis, and phagocytosis that are repurposed and tightly coordinated for tissue repair. The process involves a coordinated system of local and systemic mechanisms, the orchestra. The local response dictates the necessary systemic adjustments, while the overall neurohumoral regulation reciprocally influences local activity. The quality of recovery depends entirely on the harmony between these two realms. Leukocytes, originating primarily in the bone marrow, immigrate into the damaged zone, a process that occurs independently of the injury's localization and is precisely regulated through chemotaxis and the body's stress reactions. This migration follows a two-stage sequence defined by the class. First lane, granulocytes. Granulocytes neutrophil including arrive first, providing rapid debris clearance, and where pathogens are present, immediate antimicrobial defense. This initial activity, however, also amplifies early inflammation. Second line, agranulocytes. Granulocytes, lymphocytes, and monocytes follow, differentiating into macrophages and effector cells. Monocytes are a substantial precursor population in many contexts that contribute significantly to the pool of mobile fibroblast-like cells, fibrocytes. These critical second-wave cells clear apoptotic neutrophils. Erythrocytosis secrete growth factors such as TGF-beta and VEGF and recruit or transform into the cell necessary to build granulation tissue and re-establish structure. Crucially, the granulocytes also encompass the specific immune cells, lymphocytes, vital for specialized defense. The highly accurate kinetics of these two waves is maintained through constant intercellular signaling. The establishment of the second wave leads to the release of repellent signals but terminates the granulocyte influx. This resolution is an active, genetically regulated phase governed by specialized resolving mediators synthesized from omega-3 fatty acids. These factors coordinate the essential switch from a granulocyte-dominant response to a granulocyte-driven repair, promoting erythrocytosis and limiting tissue instability. Properly regulated resolution ensures that tissue tensile strength progressively improves. Because acute inflammation is so finely tuned, the safest medical rule, when it follows its optimal pathway, is limited to observation and control. We acknowledge that nature's perfection is consistent of context. Both insufficient and exaggerated inflammatory responses can be equally harmful. The position that intervention should be in time often oversimplifies the true clinical changes. Timing alone is insufficient. The primary criterion must be evidence of dysregulation. Intervention is only necessary when the reparative function is compromised due to disturbances or deviation from the optimal trajectory, events that can occur not rarely and in highly varied ways. Our action must therefore consist of optimizing the inflammation by gently guiding it back to its natural state. This involves targeting phase-specific checkpoints in initiation, amplification, or resolution. For example, by removing persistent triggers, supporting resolution pathways, or avoiding premature broad immunosuppression. The specific methodology for this optimization is, however, another thorn reserved for discussion in our subsequent presentations. A more detailed exposition of the Disease Optimality Principle framework can be found in our specialized monographs on this topic. Thanks for likes and sharing.